One of the things we heard from Dr. Cherney, and he kept driving this point home, that palliative care is not just the patient, it's the family. It's bringing the family together. And he spoke very eloquently and passionately about sitting the family down and having a discussion, and it begins at diagnosis.
Well, I think that's a very valid point, of course, and you know, it makes me think about, we had the first, to my mind, or in my practice as a simple medical oncologist, maybe the first group of patients where we changed this attitude were glioblastoma patients, where we wanted to have them know about prognostic issues, about their wishes, about eventual sides of treatments that they would like or not, at a moment where we would be sure that they would still be able to take their decisions, since this is a brain tumor where you eventually might end up confused or asleep, or not be able to clearly state what you would wish or not. And I think this can be generalized, and again, I think this needs education. Of course, it will be impossible for me to discuss with a patient on a first setting, the first time I see him, listen, you will benefit from palliative care. If he tells his family back home, they will be shocked. No, this is first an educational effort around the family, then of course the suffering of the family, and that was what Dr. Cherney, I think, applied to, also has to be taken into account. Yeah. And this is a team effort. They have to be brought in as far as possible. Again, this is not always easy, but it is, I think, for a large number of us now, practice to have discussions, not just patient-physician, but to have the most of the family around, so that we can fine-tune what best according to according to the state of health of the patient, of his needs, and the needs, social, psychological needs of the family.
Another point that was made that I took special note of was that death is not sometimes, I think it was talked about that death was a negative outcome. And certainly we are all going to die at some point. And so as a clinician, you have to sit back and look at that and say, well, okay, with the family there and the wishes of the patient, are we going to extend life longer, or are we going to make the best of what we can, prevent no suffering, a better quality of life? And I thought that comment about death is not always a negative outcome.
Well, I will keep it very, very personal on this, but I absolutely subscribe to this remark. And I think it's one of the first things you learn if you want to approach a patient in a palliative manner, if it is satisfactory, when you accept the fact that the outcome will be fatal. The outcome will be death in the end. But if you manage, and if your patient manage to live decent, and if you can limit the suffering to at least to the suffering that the patient is willing to accept, and help him otherwise if it is not possible. Now, this is not legally always possible all over the globe. It is in my country, Luxembourg. Then I think you can gain great satisfaction with what you're doing. And I think more in general, we have to accept that we will not necessarily be cured, or that even being cured, we will die of other means. So death is certainly something too absent in our discussion with the patient and with the family, and is not necessarily something negative. Yeah.
If you could sit back and wave your magic wand over palliative care, what would be the one thing you would really like to see in this area?
Let me understand your question better.
If you could change the way that we think about palliative care, or change the definition, or change the way it's administered, what would be the one, what one thing would you like to see different?
I would think that Our approach in medicine as a physician should be, from the beginning on, to have a sense of the well-being of the patient. Not just the disease, but the well-being of the patient. Now, these go hand in hand, of course, normally, but not always. And I think this is what, for me, this definition is, the WHO definition is all about. It starts early. It starts actually at the moment where I'm going to see my patient. And I'll try to take into account, and I'll try to solicit other healthcare professionals around me to deal with the problems, the suffering my patient has from this minute on. And if I'm conscious enough, if I can, I think this will lead to a far better quality of care and to far more satisfaction in dealing with cancer. And there again, I can tell you when I started as an oncologist as an intern in the early 90s, we had far more toxic therapies, okay. We had far worse outcome, also okay. But then we also had far, far less knowledge about the means to support a patient through his course of disease. And, well, the frustration was huge for the family, for the patient, also for the caregiver. And the state of mind which enables us now to deliver supportive care, palliative care, if we're going to the end, which was not the goal of the session, maybe terminal sedation, if we can deliver this, and if we can accept the fatality of the disease, but if we want to interfere with, if we want to raise the well-being of our patient, this gives a major satisfaction, I think, and this should be the goal.
Yeah. Well, Stephan, thanks for coming by. It was a great session, and I really appreciate everything you're doing.
Thank you very much.
Thank you.
Thank you very much indeed.